hold it like this.
Okay.
Okay? Well,
You're involved in so much.
that's what I do. But this is the proper distance.
Okay.
Okay? So anything like that?
Yeah, I've stopped doing my singing gigs, so
But some people do this.
I know.
No. Okay?
Candy.
You like that one? Yeah, I did. Hey, he will remember.
No,
Remember now to hold it up.
I'm recording in my mind to keep it that way.
Thanks.
One thing at a time, I think. 2 or 3 things get flustered.
Okay, so he's starting.
When are we starting? Sorry. Okay, brilliant. Thank you.
See you next month. Don't leave us hanging.
When you're there, if you start distributing, they can start sharing. Half and half. Oh yeah. I just want to just take some and pass them around. Sure. Okay. I don't know. There might not be enough. I don't know about 20. So, is that okay? Just one and 2 of you. If that's okay. Who's the coordinator? Is there somebody going to chair or?
I guess I'll do.
The only thing I need to know is to remind me if somebody at the other end, virtual end, they can't hear me, then I need to lift my hand.
We'll have to ask Steve if is there a way of getting feedback from the people listening, whether or not they can hear?
That's the only thing. I might get carried away and they might not want me to keep it.
Let me see what we can do. We didn't bring the gear for that.
Okay.
It's just Dr. Buzzy just asking for a reminder if they can't hear.
That's all. That's
Oh, they'll hear. They'll be recording. No problem.
yeah. Okay.
Like they don't record. You like the speaker though.
Okay. Sorry. Hello. Hi.
Just introduce Dr. Buzzy. You don't need a big introduction, do you?
No.
So you want me to introduce you first?
No, just we're happy to welcome Dr. Buzzy. Psychiatrist in the room.
Yeah.
Anxiety.
It's cool by me.
Yeah, I don't need to.
I think why don't we just go ahead and get started because we're limited
Okay.
for time.
Yeah.
So
Shall I?
If I could have this.
Yeah. Yeah.
Just to-
Sorry.
And welcome everybody. And I realize that it probably looks to you like I'm holding a microphone for no reason because there's no speakers here in the room. However, we are streaming this, and I'm pretty sure some folks, at least in Pembroke, we've actually invited Ottawa U to join us by live stream. Where's the camera? Oh, there's the camera. So even though you think the microphone is a toy, it's actually, there is a purpose for it. So welcome everybody. This is a wonderful turnout and really excited to be able to present Dr. Vazé with us. He's with the, and as you can see on the screen, with the psychiatrist. He's a psychiatrist in the Mood and Anxiety program, and he's going to talk to us today about ADHD. And if you're at all like me, this is of interest not only professionally but personally, And so let's welcome Dr. Vazé.
Thank you. Thank you, Doug. Thank you. It's really an honor to be invited here. Can I just add a few disclaimers, which I'll add later on. I do have a booming voice. My wife reminds me every day to speak quietly when we have 3- and 5-year-olds in the house. So I don't think there should be a problem, but if anybody notices my mic sort of slipping, can we just raise your hands and remind me? Because people at the other end might not be able to sort of hear it. That's me. As I said, I'm really honored. Can I thank Sarah, who works with me to organize this, invite me and people here. And I hope I can make your 1 hour useful. I'm a psychiatrist. I've just come from UK last 3 or 4 months, and people have told me how lovely the winters are. So I can't just wait to experience one. In Britain, at -1 degrees, we call it beast from the east. So we hate our rain, but we hate everything. I am currently in the mood and anxiety program, and I am actually interested in ADHD, and as hopefully through the lecture, you'll see why ADHD is nowadays thought as, in fact, a kind of a mood disorder, has a strong mood component. We've often thought of ADHD as, sorry, I thought the questions were for me. Again, another point, if people have questions, please raise their hands. Please stop me. That's the best way to learn, otherwise we all forget. I'm at the mood and anxiety program at the Royal Hospital. My interests are bipolar, depression, personality disorders, ADHD. And when psychiatrists tell you that definitely you have one or the other, I think they're lying. I think the brightest minds in the world are not sure what is what. So we have a rough idea of what kind of illnesses people have and what treatments work, and we get it right quite often, but I think all these disorders overlap on each other. And most of the time we treat symptoms. That's the core message that hopefully I'll convey as well. Before I get on to anything else, I have to do this. I have spoken on behalf of pharmaceutical companies in the past. Some of the slides have pictures on them, which I've officially downloaded for teaching, and that's why I won't be able to share all the slides, but definitely I can share some of the slides. I've not done handouts because there are too many slides, but if people want them, I can take some of them out and share them. And I have got no ongoing commercial relationships with any company regarding ADHD. And as that thing alluded to, I've got a weird Indo-Anglo, probably slightly Canadian accent as well. So if I start speaking too fast or I slip into some other words which people can't understand, feel free to stop me. I will not get offended, okay? It's important that you get clarified. Rather than we covering all the content, whatever we cover, I think I'd rather get the message across. I asked, obviously, Sarah, what people would like to hear, and she quite rightly said, initially, let's only talk about assessment of ADHD. ADHD, I do tutorials for a day, 2 days. So in 1 hour, I was just thinking of what to convey. And I thought, let me keep it basic. So if people do find that a lot of the information is basic, please excuse me. But I wanted to start basic. And if people feel later on that, yep, we know all that, can you go faster, then I'm more than happy to proceed. But let's start slow. And as I said, please stop me for clarifications. I'd want to ask any clarifications people have. We'll talk about some topical issues. My experience, I know it's only 3.5 months, but can share some of my insights. We'll go through a brief overview of depression anxiety. I think we all know it. Most of us know it correctly. But in relationship to ADHD, how to think about depression. When you're seeing a patient with depression, how to go about diagnosing or teasing out the symptoms. Then symptoms of ADHD, how to diagnose, scales, ASRS. On that note, all of you probably have a copy, or between 3 or 4 of you, we've got one copy of ASRS, which is a screening questionnaire, and DIVA, which is a diagnostic questionnaire. And I'll talk about those. If we have time, I'll touch on history of ADHD and why it's important, and prevalence, and also comorbidity. That's changing differently. So I went too fast. Do people have any particular things they want to clarify about ADHD? I usually do that with a marker. Any questions here that people want to be answered, and hopefully in an hour we can answer them. Any burning topic on their mind, clarifications? Yeah.
Are you using the term ADHD interchangeably with all of the attention disability labels that start with the letter A? ADD,
I am, because I think nowadays most of the ADHD researchers or people practicing would. Am I using ADHD as an overarching term for all the attention related or all the disorders which, like ADD? I don't know other disorders you mean, but Do you mean ADD? Yeah. Nowadays, most of the people would consider ADHD to be an umbrella term for everything related to ADHD or those kind of disorders, and particularly with ADD. Going back maybe 20, 30 years ago, ADD used to be considered a specific, different kind of illness. People who have just attention problems and not hyperactivity. But nowadays, we know that whether you have just attention or just hyperactivity or both, your general prognosis, your general response to treatment, your causes, your general symptom profile is the same. So most of us use ADHD either inattentive type or hyperactive type or combined type. Does that answer your question? Okay.
For a learning objective, looking at how ADHD connects to being a student, how people learn, and how they interact with classes.
Very good. It is. I'll try and touch on it towards the end, but I'm going to struggle to elaborate on that. But definitely, that's one of the things I'll take back. Yeah, please.
Any trends in medications and issues around medications? Because in counseling, I have some students who complain about side effects and wakefulness and insomnia and things like that affecting them. So.
And again, a very, very useful point. Unfortunately, for within 1 hour, about medication, basically. The question was about medication, whether I could talk side effects and advice. And if things work out, if there is space, I'm more than happy to come and talk about treatment of ADHD as well as separately. It'll be a huge separate topic. But today, I do apologize. I'm going to struggle.
Yes, I'm interested in teasing out some of the characteristics of ADHD with mental health, like anxiety and depression, and what are common for ADHD versus.
Brilliant. That definitely, I think I'll talk to death about that. I think you'll get bored. Yeah, please. Again, I think I probably will maybe mention a few along the way, but I think I've got a whole different slide set on myths on ADHD. And again, all these questions will help shape our future teaching sessions. Really useful questions. What I tend to hear from people is probably what's going on in some of your minds. Is it real mental illness? Are we just medicalizing some human behavior? How to reliably diagnose? Are they solid screening tests? Is medication really effective? Or just students get a bit of buzz from it? Or they just cram studies at the last minute and that's how they use it? Not students, everybody, sorry. Risk of abuse or diversion of medication? Again, I won't be able to, these are the questions that usually come up. Quite often still, does ADHD extend to adulthood, even in this day and age? And is it just a pharma industry created diagnosis, that they created a tablet first and then invented the illness? Definitely not. But these are very valid doubts that people have. It's always topical ADHD, never goes far away. I've just picked up a few headlines from local radio conversations. Within 3 months, I've heard it about 3 or 4 days that ADHD was talked about, adult ADHD. There's lots of celebrities all over the world that are coming forward and sort of talking about it to make an awareness. And in Britain, at least, we used to talk about fashion. There was a fashion of borderline personality. We used to call it emotionally unstable. Then there's a fashion of bipolar and fashion of ADHD. And although probably there was, that maybe it might prompt a few people to just go to their doctors a bit more often. But that also allowed people to come out. So I think on balance, I think celebrities are doing excellent work. Again, a slide of celebrities. And this slide is just put here to say that ADHD, you can't spot ADHD. ADHD doesn't sort of create the same symptoms. Even if the same symptom group is there, it presents as that human being presents in different ways. So you've got, normally you'd think, oops, you think athletes, you think actors, and people think of comedians and hyperactive, excitable types. But there's cooks. I think Richard Branson, people don't know him as a British entrepreneur, the Virgin Group, even quiet people like Emma Watson. So there are silent people with ADHD, there are bombastic people with ADHD. ADHD comes in all forms. Unless we really sit down and thoroughly assess their personal, the way ADHD presents with them personally, it's very difficult to know. What my experience has been so far, how are we doing for time? We've got a clock.
10 after?
Okay. Just my experience so far in UK, and again, this is not criticism. I'll come to the positives later on. But in UK, there was a big trend. In the last 10 years, they've organized every hospital, or they call it trusts. So a group of hospitals became trusts. And every hospital has got a adult ADHD service, but it is mostly for namesake at the moment. Genuine treatment, waiting lists are a year, 18 months long. But there's at least there. But outside that small group of professionals, there's a lot of reluctance to even consider ADHD. Oh, no, can't be. Oh, I don't do ADHD. I don't do stimulants. I don't understand. And sadly, that's been allowed to go on. Psychiatrists should generally be treating ADHD. Most of the psychiatrists should understand some level. Some might be a bit more experienced than others. But in UK, there's definitely huge resistance. And huge fear of prescription of stimulants. I was at a educational session a few months ago. I was talking to volunteers and I think some carers, and I said, honestly, stimulants are much safer than those candies and sweets that you see at the checkout counters in supermarkets, and their jaws drop. How can you say that? I said, they are. They genuinely are. There's massive fear because they're called stimulants. So within our sort of ADHD group, we've been also thinking about this term, that the word stimulant suddenly scares people. Yes, the mechanism of action is like street stimulants, but it's much safer, highly, highly unlikely to be seriously abused, and doesn't give any buzz, doesn't give any actual euphoric feeling unless you really, really crush it, inject it, and you have to work really hard to get a high from ADHD drugs. In Canada, in Ottawa at least, I can say, there's no actual organized services, so no clinic or program, but overall, there's a lot of comfort. I've seen GPs, I've seen psychiatrists, physicians. We're comfortable with diagnosing or treating with stimulants. And it's really, really encouraging, reassuring. As I said, even on symptomatic basis. So we've got depression, the tiredness and depression not getting better. Let's try a bit of stimulant. As long as we do checks and make sure we're safely doing it, there's absolutely no harm. And my experience of treating Algong, so I get referrals from to my Royal Hospital directly from here. We've got an OTN clinic, so I see patients, and Tafima helps us. And my experience so far of the diagnosis made here by clinicians or generally patients going through is the diagnosis is almost always appropriate. It's not been overdiagnosed. I don't know if people have fears that, oh, everybody's got ADHD nowadays. It isn't. People are being diagnosed because for years and decades there's been huge underdiagnosis. So now we're finding all the patients or people who actually haven't been diagnosed. So people feel that there's overdiagnosis. It's highly unlikely. Medication, again, from this college, the patients and students that I've seen, they've been very sort of appropriately prescribed. And patients, and I'm not just saying that because I've been invited here, please, patients do speak highly of staff here. Amazing support, amazing patience, asking questions. Patients, oh, this is nice. I like this. I like my voice anyway. It's twice now. Accommodations. I'm conscious of using the local terms. We call it adjustments there. But employment or student accommodations, extra time, support, really, really nice sort of culture. So what do we specialists do? Why do you think we are special? Why do we think that we get maybe some people slightly better than maybe GPs or other professionals? We don't. But because we get that specialist label. Patients, oh yeah, this doctor, this royal doctor is giving me this tablet, must be a magic pill. It does work. That's how, and probably the selling, I think, they should have a marketing module in medical school of how to market yourself and market your treatment. There aren't any clinical studies which will tell us. If people have read or heard, there are anecdotal evidences. I'm sure individual patients will tell you, yep, this particular stimulant works for those kind of symptoms, and amphetamine works for hyperactivity, and Strattera works for depression. There aren't any consistent, conclusive clinical studies to show which medication will work in what kind of ADHD. So it is a trial and error thing. We are guided by what side effects people have and what people's choice is and how they can take the medication, so whether it's slow release or quick release or practical aspects, money, insurance, what covers it. It's a completely new thing for me to think about it. The trick is, if there is something that maybe we do differently, is we treat the right symptoms at the right time. We maybe not even get the right diagnosis, or we're not better at diagnosing than any GPs or psychiatrists. But at that moment, if a patient is presenting in an anxious episode, then it's important for him to feel that immediately better. So we treat the anxiety at that time. So to diagnose anxiety is slightly different from hyperactive ADHD. That's maybe what we do. So when you treat it, then they don't get the side effects. If you start somebody with stimulants when they're going through an anxious episode, then they're going to not, again, their faith is going to be lost in medication. So what we probably do is carefully, very carefully, over 2 or 3 sessions, assess what is the actual episode, what are the symptoms, what to treat, when, and probably maybe that improves patients' faith. And we also do is we are boringly slow. We really drag it out. So in a lot of private clinics or patients, quite often, oh, I want to increase my medication every week, every 2 weeks. No. I tell them, no, I'm going to go slow. And that does 2 or 3 things. One is it actually helps us find out whether the medication is working or not. So if you give it long time, ADHD doesn't affect people's everyday life. I mean, it affects most of things. But the problems, the disorganization, the forgetfulness, the misplacing things, the hyperactivity, the impulsiveness, that might not happen every day, every second day. So if you give it longer, to notice improvement is much more easier. Or if you have a shorter period, within a week, oh, I don't think it's done anything. But then you give it a month and they say, oh yeah, I would have normally lost my way to go to Royal, but this time I didn't. I actually went there in time. Or last 2 appointments I attended in time. So the longer period you give, the more chances that you can, and this is true for any mental illness, I think you have to go slow with increasing. Painful for patients, absolutely painful, completely agree. But that's the best chance rather than rapidly increasing. Medication tolerance is better. If they have side effects, usually most of the psychiatric drug side effects settle down within a week or 2, if they're not too uncomfortable. So again, going very, very slowly is the name of the game. And realistic expectations of what will improve. I think from the beginning, oh, you're going to get better and you're going to start working and sort of keep every job or keep every relationship. We'd like to give them hope, but also realism. Maybe it'll be a bumpy ride initially. Things are get better stepwise, maybe 1 or 2 knocks you'll have, maybe you'll still struggle, but then overall review over 1 or 2 months and see if it gets better. So, and ADHD has mood instability as a core symptom. That's again a message that hopefully I will convey at the end of the hour. You've got the attention symptoms, you've got the hyperactivity symptoms, but also a huge group of mood instability. Different names in different journal articles: emotional dysregulation, emotional instability, mood swings. That is a core symptom of ADHD. That does not mean that they have borderline personality necessarily. That doesn't mean that they have bipolar. That doesn't mean that they're just moody and mardy and just obnoxious. The actual biological chemicals in their brain do swing to cause mood swings. So what would an assessment process look like? It's a standard psychiatric assessment. I don't know if people are aware of this. We usually go through initial symptoms, then family history. Oops. Yeah. You can see I'm not really coordinated. I think 2 or 3 things are too much in my hand. Psychiatric comorbidity, so we'll touch on it later on. Family history, particularly ADHD. And if you're assessing somebody, does anybody in the family have ADHD? And you would be really, really missed to find not a single member. Very rarely people will say, oh, nobody. If they've not been diagnosed, it's somebody similar to you, somebody a bit forgetful, a bit disorganized, a bit scatterbrained. And when you apologize before saying that, people don't take that as an offense. You say, I'm sorry to ask it this way, but have you always thought of yourself as a class clown? Or a bit scatterbrained, a bit forgetful? Or is somebody in the family like this? Or is somebody in the family using drugs to cope with these symptoms? Maybe. So there are different ways of asking family history rather than just family definite diagnosis. Then detailed milestones, and I'm really, my trainees or resident doctors, they get really grilled if they don't ask for absolute every detail in there. I don't want to know what they've achieved. I don't want to know whether they've got grades or honors or whatever in the degrees. I want to know, while doing that, did they struggle? So in our ADHD clinic in UK, here we see highly successful people. We see lawyers, we see doctors, we see professors, we see big businessmen. So it's not what they have achieved, but it's during their achievement, how did they go through? Did they struggle at every point? Did they get stressed? Because they couldn't focus, because they have that, what I call as an achievement chasm. So they always thought that they can do better than they are. And it's a very prominent ADHD symptom, that they feel, I don't know why I can't get there. I can see my potential. I know I can do these things. But there are brief periods of better feelings. So all these are useful. So I'll ask them, okay, while studying, how was your concentration? Not whether you could get enough grades, because intelligence can compensate. There are lots of reports which tell us intelligence can't, but intelligence can. Medical history, you'd want to get in detail, particularly heart problems, cardiac history, and collateral history. It's not always essential, but in childhood ADHD, I think they depend on that for diagnosis. I don't know the exact process here, but in UK, they had to triangulate an assessment. So a clinician, a doctor, or even a specialist nurse had to observe the ADHD, parents had to agree, and teachers had to agree. Here, I don't know whether childhood diagnosis needs that triangulation. But in adults, I'm really fortunate that I'm allowed to believe in a patient. It sounds very odd, but people who aren't ADHD, who don't accept ADHD, what do you think patients are lying? Do you think patients could be lying? Could they be pulling the wool over your face? And that's a question that maybe all students or people who come to psychiatry ask. And my response is same. I don't start with that assumption. I really don't start with the assumption that they're going to lie. They might be lying. I don't know. I'm not a magician. But most of the time, if I have that doubt at the back of my mind, I won't be able to give them the true service. So I tend to believe in them, maybe naively. And believing in them, and sorry, I'm digressing it, but believing in them does two things. One, it allows me to confidently diagnose because there's no other magic diagnostic tool apart from interview. And secondly, even if they are lying, I've built a good therapeutic rapport with them. And few weeks, months down the line, I can gently challenge them. Well, you said that. Was that really true? And they're much more comfortable to accept, well, it wasn't like that maybe. So believing in a patient, as simple and as basic as it sounds, I do that. And throughout my career, I haven't gone on to found that a lot of people have actually lied for, I don't know, benefits or for secondary gains like finances or insurance. So again, I'm going to go through very basic concepts of depression, but touch on things that might differentiate depression from other things. By the way, is the pace okay? Is that okay? Thank you. My accent okay? Yeah, please say yes. I'll tell my wife. We all know depression. When it's low mood, low motivation, tiredness, poor appetite, poor sleep, guilt, self-blame, low libido, hopelessness, worthless, helplessness. Does that sound like most of the depression symptoms? Can people think whether there's some one word that's missing from all that that could make this different things, make this into 5 different diagnoses? No? If it was a medical student teaching, I would pick people, but I'm not going to be cruel. Consistent. It sounds very basic, very, very basic, and quite often I have to remind myself. But every question about most mental health assessments is, have you consistently felt that way? By consistent, I don't mean every moment or every day, but most of the time, 95% of the time. So again, depression, over the last 2 or 3 weeks or 4 weeks, whatever the criteria are, have you felt consistently low? Or have you felt frequently low, but also have better days? And then completely the diagnostic process changes. So consistently low, okay. And then has your appetite been consistently bad most of the days? Has your motivation been consistently bad? Or once or twice a week, if your friends come and take you out for dinner, your mood improves. So again, if there are, 2 or 3 days a week, or at least 1 or 2 days a week that they are not that low, then you're looking at emotional instability rather than a classical depressive. And the reason for teasing that out is antidepressants would work when you've got the diagnosis right, when depression diagnosis. Quite often, we see that the reason antidepressants are not working is because they don't have depression, at least not at that time. They might have mood instability associated with ADHD, or maybe bipolar, or trauma-related mood swings, or drug and alcohol abuse-related mood swings. So as basic as that sounds, that's quite useful, consistent. Oh, I put these silly animations in. Anxiety. And again, all of us know anxiety. But quite often, to tease ADHD from anxiety, I give them an example of racing thoughts. So many people come to my clinic and say they have anxiety, but what they actually mean is that the thoughts are going at 1,000 miles an hour, that their mind is never quiet, mind never sits calmly. But all the time, the thoughts are not necessarily anxious. They're not about worry or dread or fear. They're just innocuous thoughts, daily thoughts. What am I doing? Where am I going to go for dining, or what's going to happen on TV, or what am I going to wear tomorrow? All these thoughts and a constant mental stream of thoughts is very classical of ADHD, whether you have inattentive or hyperactive. But unless it's accompanied by anxiety, or by anxiety I mean anxious cognitions or anxious thoughts, so that's fear, dread, catastrophic thinking, then that's not anxiety. Or it's definitely not generalized anxiety. People can have variable anxiety. And then you have the other anxiety types, the OCDs and the PTSDs, and that's different. But the core, one symptom of all anxiety disorders is worry. And quite often people confuse racing thoughts associated with ADHD from worry. So again, as people, oh, I've got these physical symptoms, I'm agitated, I'm restless, oh, you must be anxious. No. Is the agitation and restlessness associated with mental worry? So that will only become a symptom of anxiety when you're mentally worrying. You might not be worrying about something specific, but it could be general free-floating anxiety. It could be generalized anxiety. So it could be just dread and fear about something, some unknown consequence. And then if you have palpitations, breathlessness, agitation, restlessness, pacing, then it becomes a physical or autonomic symptom of anxiety. But when you just have the physical bit without the anxious thoughts, then it could be ADHD. It could be a clue that maybe there's a hyperactive ADHD. I've just explained that. And then if they are genuinely anxious, then it's impossible to assess at that time. Then we treat the anxiety and reassess. Bipolar, again, it's a very basic concept, but I show them this in the clinic. This is, does your mood go high? When you say you're high, and firstly when people come with, oh, I've got bipolar, okay, tell me, I have highs. What do you mean? Well, I run around, I'm pacing, I'm agitated, I overspend. Do you actually feel high? And by high, again, do you actually feel elated? Do you actually feel higher than normal? Do you feel overconfident? Do you feel your anxiety goes away almost or gets very minimal? And that is such a crucial sort of clarification of elated mood. And again, when you're looking at bipolar, sorry, did you raise your hand? Sorry, I just thought. So, okay. Yeah, sorry. Yeah. High mood. So again, clarification of elated mood. And then along with elated mood, I don't know whether people can see this, but it's lack of need for sleep. So not just insomnia, not just inability to sleep. All of us have that. But it's, I don't need sleep, that particular episode. So again, it's, do you feel consistently high? And during that period, do you consistently feel excessive libido? Consistently high libido for 4 or 5 days or more. I think teenagers brag about this, but I don't think most of the people have this consistently for 4 or 5 days. Yeah, you can have more physical relationships in the first few months or initial period of a new relationship, it's excitable, but consistent episodic pattern of high libido is very unusual to happen anywhere else. Over-talkativeness, flight of ideas, hyperactivity, all these can be in other states as well. So that's why I like lack of need for sleep and high libido as core manic or hypomanic symptoms. And then we have the depression, which lasts for 2 weeks minimum, both DSM and ICD-10. So 4 days. And what happens? I think I'll probably got a slide later on in ADHD. So coming to ADHD diagnosis, so we've got all your DSM, the DSM-4 related DIVA questionnaire. I'm not going to go through every question, but we'll just sample a few. All of these sound very similar, don't they? Inability to give close attention. So there are 9 attention symptoms. You might think, oh, everything is similar, or all of us have this. Come on, you can't diagnose ADHD based on this. When you actually get into the assessment of every symptom, that's when you clarify whether it's frequent, impairing, very, very sort of annoying, cause a lot of problems in their life, and you have to tease out whether that is the real problem or not. So we'll take a few examples, but there are 9 symptoms in attention, 6 in hyperactivity, and 3 in impulsivity. So 9 in 2 groups. Okay, 9 attention, and 9, and this hyperactivity impulsivity group is taken together as 9, 6 and 9. And we'll come to the diagnostic criteria later on. But when you do basic screening, ASRS, a lovely, simple instrument, you've got, I think you're sharing between you two, the 1-page questionnaire. It's got 18 questions. Again, as you can see, the 18 are related to the 18 symptoms. They've done research and found that the first 6 are in fact the most accurate. So if you're pressed for time, use the first 6. But although they don't clarify, can I advise that when you're asking patients to, and it's a self-report, so you can give it to patients, when you're asking them to score this, please ask them, when your mood and anxiety is okay, and that's, I think I'm going to probably put that here. So when your mood and anxiety are stable, when you're not, unwell in any way, when you're not drinking, taking drugs, when you're not going through a major life event, job loss, relationship breakup, when you're generally okay-ish, whatever your okay baseline is, as if it's part of your personality. So again, that took me about 7 seconds to say, and I'll repeat that if necessary. Have you frequently forgotten to, have you struggled to focus? So during everything, so watching TV, do you find that you have to rewind it quite frequently? Do you find that when you read, you have to reread it? Yeah, you enjoy reading. That doesn't mean you don't have problems in reading. So you might read, but then have to reread. And a common answer when I ask these questions is, I do have problems in things that I don't like. And things I like, I don't have any problems. And again, a way I go about that is, okay, put all those things together. You think you like and you don't like. Considering all the things that you need to focus on, do you struggle more often than not? And it's not a scientifically valid way, but it's a very useful way of teasing out whether that something is a problem. So focusing on books, or some books are non-fiction I love, fiction I don't like. I said, okay, fiction or non-fiction I don't like, and fiction I love. But putting all those things together, reading newspaper, reading correspondence, everything, do you struggle? And then you get the real answer, more often than not. And then you tease it again. What happens when you do this? What happens when you do that? And ask them to give specific examples. So simple questions. Have you frequently been distractible? Again, when you're generally okay in life, does your mind just wander constantly? And if they say yes, please don't think, oh, everybody's going to answer yes to that. They don't. When you actually ask them for examples, quite a few people generally say no. Have you frequently been forgetful? Have you or always people thought that you're a bit scatterbrained? Or have you struggled to sit down for long durations? Or you frequently had mood swings without a clear reason? And these are the questions. So the questions that I just said are just general interview questions when you've got 5 minutes and you can want to do that. Or you can give patients these. But please put a question at the top, or at least tell them, score this at times in your life when your mood, anxiety is okay, you're not stressed, you're not sort of had bad sleep, and then score it. And if they come out positive, now in the sheets that I've given you the scoring criteria as well. So DIVA, I've put DIVA 5 here because it's based on DSM-5. I don't know if people know. DSM is the North American classification system. ICD-10 is the European or WHO one. And unfortunately, it's so good that most of the ADHD experts or specialists use DSM. And I don't know how they managed to do a patent on diagnostic criteria, but they have. So they've patented diagnostic criteria. So if you want to use, and in ADHD, I was laughing 2 or 3 days ago, I found out that if you want to use DSM-5 criteria for ADHD using the same forms, and the only change is that in adult ADHD, you have to have 5 out of 9 in any one category. Okay? So if you remember the attention, the hyperactivity, impulsivity, 9, you need to score 5 out of 1 category to have one kind of ADHD. How can they have patented that? I'd love to understand that. But they have. So what my European colleagues had done actually is come out with a DSM-based questionnaire, which is free to use, not copyrighted. Really all of us in UK use that. But what I've advised, I've given you copies of DSM-4. And there is no rule to say that you can't score it by DSM-5 method. I haven't seen any language. But if you have to use that particular piece of paper, then you have to pay them some money. So are you okay? So the question in front of you is exactly the same questions, but if patients score 5 out of 9, then nowadays they're called ADHD. Previously, you needed 6 out of 9. So I didn't clarify that. So in 2013, DSM-5 came up and say, well, actually, we're missing a lot of patients with ADHD. So till then, the criteria were you needed 6 out of 9 in one category, either attention or hyperactivity, or both. But nowadays, you just need 5 out of 9. Is that okay? Is that clarified? So you can still use the DSM-4 scales, but apply the DSM-5 criteria, because you'll get accurately a good mix. How are we doing for time? Sorry.
25 minutes.
2.
25.
So left. Thank you. Sorry. Nitpicky end. I'll skip that. If you can, there's a very nice introduction, very easy to use scale. Feel free to use it. I've been told it's not copyrighted, but I'm sure you can figure that out. So it basically says, when you sit with the patients, preferably sit with somebody who can give collateral information, who can give answers to the childhood, and we'll look at 2 or 3 symptoms and how to do that. And first ask the current symptoms to patient, or if they've come with current partner, friend, and then ask the childhood to relatives or family, parents, or even siblings. And if there's a disagreement between patient and family about childhood events, believe the patient. I love this. So it is such a core thing of what we do, believe the patient. And it had to be said by them. A lot of my colleagues who were cynical about 10 years ago, well, no, unless I get collateral information from family, I'm not going to diagnose. There isn't a rule that says that. It says it's advisable. Yes, you try and ask the patients to bring somebody, so it's a nice wholesome assessment, but you don't have to. If they say, patient says, I remember struggling, that's it. So let's take the first, for example. Do you often fail to give close attention to detail, or do you make careless mistakes in your work or during other activities? And how was that during childhood? Very nicely framed. Feel free to just sort of read it out to them. And if they ask, okay, what do you mean? Then explain. Okay, meaning careless mistakes. So if you're in childhood, if you're reading your question paper or material that you've been given, do you tend to read it quite fast? Or read it quite slow, very slowly? And there's a concept of hyperfocus. I don't know whether people have heard about ADHD hyperfocus. And people sometimes think that's a symptom of ADHD. It can happen. It's not a productive hyperfocusing. Some people actually who have poor focus will skip through things. Oh, I can't be bothered. I'm going to read that. Yeah, I've understood. But then make errors. That could be in letters, that could be in bills, that could be in internet information, that could be in very important things. But they just do not have the patience to sit down and carefully go through one line, one statement at a time. If they're reading books, and in my family there are a lot of, I finished a book in 3 days or 2 days, a big thick book. When I used to feel really bad, as my sister. And I said, how do you read it? Oh, I skim read. I said, that's not fair. I could only go through 10 pages. And yeah, they just get, she wasn't, and I've been forcing the diagnosis on her, but she's not ADHD. But a lot of people with ADHD would do that, would skim read. Unfortunately, some people do manage to get the gist and enjoy, and that's good for them. But if it causes problems, then it becomes a symptom. So if important things, they're skim reading, of reading fast. So coming to hyperfocus, some people, because they struggle, if they've got anxiety and they've got a perfectionist trait, then they would get bogged down. No, I need to get this in my brain. So they'd go over once, twice, 3 times. It's not necessarily because they're perfectionist, but it's because they can't focus. They could be still perfectionists. They could want to get it absolutely perfect. But then you have to tease out whether there's perfectionism in other areas. But quite often people there's overlap. Again, if people are, for example, hyper-organized or very obsessive about things, or they've got OCD, they might have obsessive traits. And we'll come to a couple of teasing out diagnosis. So again, people ask me, well, do they have to take 1 or 2 or 4? They don't. They don't have to take 1 or they don't have to take all. This is just a guideline on how that symptom can present. So if patients say definitely yes, a problem, then just move on. If they say, well, I don't know what I mean, then give them prompts. So these are prompts for us to actually make them understand that question. Is that okay? So a very helpful, gentle questionnaire. Sometimes when I'm absolutely confident that patients are not going to over-report or they're going to genuinely understand, I do give it to them to take home. But most of the times I sit with them to explain how the questionnaire works. So all the questions, we'll take another one. Do you often find it difficult to sustain? So again, all of them might sound very similar. The first one is about taking information in for short periods and retaining it enough to understand. The second is, when you're starting to do an activity, can you sustain your attention? Or does your mind wander here, there? Does your mind, maybe related things, maybe related to the area, but does that then not allow you to come back or come back late or you get bored with what was happening? So again, is sustaining attention a problem? And again, prompts. If you see the prompts, finds it difficult to watch a film through the end, quickly getting bored, ask questions about subjects that have already been discussed. So there are those kind of prompts, they're prompts mainly for us rather than the patient. If they don't understand the question, then we clarify it for them. Sometimes they give a completely new example rather than include any of them. And what they've done is they've said, okay, in childhood, that symptom might have presented like this. In adulthood, it presents like this. So the symptom criteria in childhood and adulthood are exactly the same. In adulthood, according to DSM-5, you just need 5 out of 9. Whereas in childhood, so if somebody's under 17, they still need 6 out of 9. Again, we've not understood that. A3, again, if you go through the question at your own place, and this is freely available, not copyrighted. If you just Google DSM-4 DIVA ADHD, you'll get that whole questionnaire. Distractibility. So again, this question is about distractibility. Are you listening when somebody's talking or not? So I wasn't going to go through every questionnaire, but you can see how it is used, isn't it? Any questions? No? Okay, and similarly then you've got the A9, so there are 9 questions of attention. And then you'll have the hyperactivity questions. And again, just take one. Do you often stand up in situations where the expectation is that you remain in your seat? So genuine hyperactivity, needing to be on the go all the time. And again, the examples could be never sits for long, stressed, owing to difficulty of sitting still, make excuses. And as you work with more patients, you'll see that patients quite classically, when they have it, they quite classically have it. People often get worried, oh, I'm not sure whether this is ADHD or not. 10 years of working in ADHD, I can tell you very few people are on the fence. They either have it or don't have it. So that worries, it doesn't sort of pan out in the clinics. I think we probably have 15 minutes. I think that's all I was going to talk about, assessment, and I was going to then take about prevalence and comorbidity. Is that okay?
You okay?
Yeah. I thought I'd be stopped more by people, but I spellbound them.
You're talking so fast, I can't
I know. Please stop me. I do talk fast. I always talk fast, not just when I'm anxious. I need to remove that animation, isn't it? It's really boring. So, as I said, DSM-5, 3 types, inattentive, hyperactive combined. For younger age group, 6 out of 9 symptoms. So that's 6 out of 9. For adults, 5 out of 9. And the other criteria is the onset of symptoms should be before the age of 12. And again, you don't need to have all the symptoms, you just need to have some. So basically, essentially you need to confirm that this is a developmental illness. By that I mean that it started at some point in childhood. And again, there are lots of debates on people, well, I never had any problems until 13 or 14. And what they quite often mean is that no problems were sort of identified or no issues came up in school, because they might not be hyperactive, or they might not be problematic, or they might not have other comorbid issues like oppositional defiant disorder or substance misuse. So they silently went under the radar. And most probably they might have inattentive ADHD, but probably were reasonably intelligent. So they managed things at the last minute. So the teachers never realized any problems. So many times, 15, 16, I get it from patients that, yeah, definitely I didn't have any problems till 15. When you really drill deep, well, actually, yeah, I was clever enough to do it quickly. Well, maybe you were clever, and maybe that was applicable. And the reason they struggle later on is, whether you're clever or not, later high school, college, university, almost all of us have to knuckle down and put in the R's. So when they have to put in the R's, irrespective of intelligence, that's when the problems come out. But the problems were there before. It's just that whatever their social, if they have a stable social situation, if they have fairly reasonable sort of family atmosphere, if their parents realize, well, there's lots of energy, we need to direct them to sports. If that has happened, so if they are quite sort of productively active, then that gets the energy out. That doesn't leave them angry, irritable. So if those things have happened, then problems don't come to light. And in ICD-10, so where I used to practice, they actually only had one type. You could not diagnose 3 types. And the criteria was so strict that a lot of people were missed. So unless you had, if you remember the 9 criteria, so unless you had 3 out of 5 from the attention group, 3 out of 5 in hyperactive, and 1 out of 4 in impulsive. So all of them, you couldn't diagnose as ADHD. So imagine how many people were missed. And the onset of, onset, they had to be before 7. And again, before 7, it's very difficult. Very, very good question. Yes, you can have ADHD-like symptoms, and you can have ADHD acquired. Sorry. Can you acquire ADHD by head injury? And I'm glad you asked head injury, because yes, you can. A lot of people who have head injuries have ADHD-like symptoms and a clear onset from the time of head injury. We still call it ADHD, even if it is due to head injury. So we'll have to do an assessment of seeing pre-head injury states. And they do respond to medication as well. But that probably is the only, maybe head injury and infections is the only time that you can acquire it. All other myths, and I'm calling myths, that bad parenting, I think parental separation, childhood abuse of any kind, drugs, diet, all these cannot cause ADHD. They can cause ADHD-like symptoms. So if you wait long enough and you somehow manage to get the people off the drugs or manage that situation and then reassess, if they still have the symptoms, then you call it ADHD. So ADHD cannot call, it is biological. It is as biological as it gets. And I'll show you a slide if you have time of, we all think mental illnesses are strongly inherited in families. Top of the tree is autism spectrum disorders, so Asperger's and all of that. Second is ADHD. It's much more strongly inherited in families than your depressions, your bipolar, your schizophrenia, or everything. So very, very strongly genetics. That's why I initially said if you find a patient with ADHD, you will find somebody in their close or slightly extended family with ADHD. Very strong chance. Is that okay? I won't go through. There's lots of neuropsychological tests. Again, scales. There are umpteen number. I think daily they're coming up with new scales. In UK, there is Europe actually. There's a new, not quite a fad. It's a useful tool, but an objective test of ADHD. So it involves having motion cameras and actigraphy and a combination of that. And then I'd like to sort of spend time on latter issues. So people read it. It's not achieved clinical applicability as yet, but it's a good, helpful tool in when you're not clear whether it is ADHD or it is anxiety or something else. It is useful to tease out. It's useful to monitor, but that's probably one of the more objective tests. But still, every expert, every article, every journal article would say clinical interview with maybe structured questionnaires is still the best way. It's still probably the only way to diagnose. So overall prevalence, sorry, a time check, if you don't mind. 10-2. Okay. Sorry, I had to check that again, didn't I? Overall prevalence, I think I'm going to go a bit faster on the overall prevalence. I think people probably know this, 4% of the whole population. And this is national, this is international. This is not just American, Canadian, European. This is worldwide. Not on its own as diagnosis. Continuous performance test. It's for research, they use it as a tool, but on its own, it's not a valid test for diagnostics. It's a helpful tool. It facilitates diagnosis with the questionnaire and with clinical interview. And clinical interview is, again, necessary to rule out all the other comorbidities that I said. So clinical interview, there's absolutely no way we can do without it. But it's a very, very helpful tool. And they're getting more advanced and more sort of ways of getting more, the accuracy more. So the prevalence is high. And just one slide. So this is adult, oops. God. So this is adult ADHD, 2 to 4% of the population. And this is verified by every study done nowadays internationally. From Eastern countries, China, Taiwan, India, Sri Lanka, European countries, American literature, between 2 to 4% is adult ADHD. And if you think of the other mental illnesses, you've got bipolar, 1 to 3%, depression, 4%, substance misuse, 1 to 3%, learning disability, 1 to 2%. It's still considered a marginal or a rare or uncommon disorder, and it's still not given that much importance. At least in European countries, it isn't. So again, it baffles me why. Again, I'm just going to go through prevalence. Lots of proof for prevalence in different countries. Prevalence in prisons, as expected, high, around 30-40%. Prevalence in substance misuse services, very, very common. Comorbidities, and again, just want to spend some time with that. So these are the more frequent comorbidities that happen with ADHD. Borderline personality disorder, and again, I think it's a very poorly understood and I think poorly propagated diagnosis, in my opinion. In short, my personal belief, and it's a growing belief, that when this diagnosis was made and established in the whole, not just psychiatric, but general population mindset, ADHD was not considered strongly. So what now we're finding is a lot of people with BPD diagnosis, if you review them carefully, they'll have maybe a mild bipolar diagnosis, or quite often an ADHD diagnosis that's missed because the symptoms are so common. So we'll touch on them quickly. This is to say ADHD looks like a lot of disorders, but it also occurs along with other disorders. And that's the tricky bit, that you have to tease it from other disorders, but you also have to keep in mind that people have other disorders on top of ADHD. So comorbidity in ADHD, so out of 100 patients with ADHD, adult ADHD, about 30 to 40% will have any mood disorder, 20% bipolar, 40% anxiety, 15% substance misuse, and in 100 patients with other mood disorders, how many of them have ADHD? So in 100 with bipolar, 20 would have ADHD, and so on. So huge overlap. We did a survey in UK, and we found that at least half of patients had 2 diagnoses, not just one. And we did a paper, and what that shows was that, so this is basically the range. If you see 10, 20, these are percentage of patients in adult psychiatric population. So say where I work in the mood program, in that kind of, out of 1,000 patients, we are seeing different countries show different figures, but 10 to 20% might have ADHD in a sort of secondary care adult psychiatric clinic, but it gets missed. So what's going on? Why does ADHD come with so many different disorders? Common genes, and this is a paper, it's a landmark paper which tells us that mental illness are not inherited true. So there are 4 or 5, there are about 10, 12 genetic loci or genetic spots, which actually give rise to 5 different major mental illnesses. So unfortunately, that's what creates cross-inheritance in families. That if a family member has one mental illness, all of the family members have got more vulnerability for lots of other mental illnesses, not just that same one. Because similar genes, because of different life experiences, because of what happens in pregnancy, uterus, growing up, might present as different things. So one gene can sometimes present as bipolar when they grow up, or can go ADHD. And this is not because we've got it wrong, this is how the sort of mental illnesses work at the moment. The neurobiology is also quite common. So if people ask, can I not have a scan to find out ADHD? Well, yes, a scan will tell an ADHD brain apart from healthy controls. So definitely there are brain abnormalities. But a scan can't differentiate whether somebody has ADHD or bipolar or anxiety, because the areas that are affected in all these mental illnesses are very similar, if not exactly the same. So quick look at schizophrenia. If you look at the names of these areas, and I'm not just impressing you with my knowledge of the brain, but if you see PFC, prefrontal cortex, these are the thalamus, so these are deeper brain areas, these are memory-related, emotional areas, that's schizophrenia, and you'll see the overlap. This is the mood disorders, depression and bipolar, pretty much similar areas affected. So we don't know. We're finding it, we're doing more and more research every day. This is ADHD. Again, the orbitofrontal cortex, dorsolateral prefrontal cortex, so the frontal lobe, which is the part of our brain which actually separates us from animals. This is the part of our brain which is the seat of executive function. That's where we plan, we execute, with our personality, our artistic talents, our speech. The rest of the animalistic drives are deeper, but that's where the ADHD symptoms are. So if you think of ADHD, concentration, impulsivity, disorganization, most of this problem in the dopamine. Sorry, I wasn't given more than 1 hour, that's why I said 1 hour is quite frustrating. I think I'll probably wrap up, but there's a huge overlap of ADHD. I'm going to probably, so what I was showing here was that there's a huge overlap of ADHD and other disorders, like we've talked about. But is that because we've got the diagnostic boundaries too wide? Maybe, I don't know. Our diagnostic boundaries are reviewed every few years, and some critics might argue, well, 5 out of 9. So that means anybody in the street can tick 5 out of 9 symptoms. Maybe. We don't know whether we've got them exactly right. We change those boundaries depending on research, so brain research and biological research, genetic research. But we don't also want to make them too small, so that a lot of people with genuine illnesses fall through the gaps. And I want to just show up for the mind, the gap, you know. That's why I got this side. So there is no right way. At the moment, I think we've got it right, at least in ADHD, but every few years it evolves. 2 or 3 slides and I'll finish, promise. So bipolar, how to tease out bipolar from ADHD mood swings. So bipolar, it's obvious. In ADHD, the onset is childhood. At some point, 7, 8, 9. There are other indicators, and poor sleep. And in adulthood, adult bipolar anyway, the onset is in adulthood. I know there's a childhood bipolar concept, but it's still not reached very popular or very confirmatory sort of conclusion. We don't know whether childhood bipolar is really bipolar or whether it's ADHD. There's still a lot of debate going on in scientific circles. But most of the bipolar, at least bipolar 2, including bipolar 2, starts in adulthood, 20s. So if somebody's mood swings have started way earlier, think ADHD. At least 1 point in favor of ADHD. And then when you go down, you say, okay, 1 here, 2 here. That's how we make the diagnosis. There's more evidence for this or more evidence for that. Then pervasive, ADHD presents like a part of their personality. And another way I describe it is part of your personality. What we've done is we've taken a chunk of your personality, your quirks, which were, decades ago they were called quirks, or scatterbrain personality traits, and we've looked at them and they behave like an illness. So they've got brain changes, they've got treatments, they've got prognosis. So is it a pervasive, continuous illness, as opposed to bipolar, which is episodic, like we saw on the slide. ADHD does cause highs. compared to the other disorders where the genuine highs are not there, but they're brief, few hours or a day, or they just get carried away with good events. Whereas in bipolar, we've seen sustained elated mood. The sleep problems are different. In ADHD, there are delayed sleep patterns, and then they go to bed quite late. And again, it is often with a biological reason that their melatonin peak actually happens later in their evenings as compared to early in the evenings. So giving them a lot of sleep hygiene measures is good, it might work, but not penalizing them if that doesn't work. And if the world were really, really empathic, which we all know it can't be, their offices and work and colleges would start at 1 o'clock, and then they would do better. But the whole world wants to start at 8 o'clock, and you can't with an ADHD patient. Mood instability, ADHD, as I said, it's rapid mood swings. We're looking at a graph. No genuine grandiosity, the brief sort of hyperexcitability, overconfidence, but a genuine feeling of superiority over other people is not there, which is there in bipolar. In ADHD, you get impulsive sexual behavior, but it's part of the risk-taking behavior rather than a genuine increased libido, not a constant increased drive. Maybe. I don't want to confuse you further, but some ADHD patients have a heightened sexual drive all their lives, but there's a different reason for that. And again, with treatment, if you try usual treatments of bipolar, your lithiums, your lamotrigines, or even antidepressants, not a good idea. They don't have no difference in ADHD, or in fact, quite the reverse. They are difficult to tolerate because people become more agitated and anxious. Whereas antidepressants should be prescribed in bipolar, but they do lift people's mood. And that's how a bipolar sort of mood swing pattern looks like. That's how ADHD looks like. It still has highs, but rapid. And then the other common misperception is borderline. And in borderline, mood swings or self-harm are not the core symptoms. The one core symptom, if there is constant insecurity, constant fear of rejection, constant feeling that people are going to leave them, constant low self-esteem, confidence. True, it's common to a lot of these disorders. But if it is very, very prevalent in every relationship, not just romantic relationship, but every friendship, then think about borderline. Self-harm and mood swings and sort of relationship issues and intense relationships, they can be symptom of a lot of things. But once you get the core rejection sensitivity, maybe there is borderline. But in pure ADHD, whatever pure ADHD means, without any comorbidity, that's not there. In fact, they can end relationships easily. And that's because the emotion or the feeling or the memory doesn't stay. So in fact, it sounds very odd, but my experience is people who are traumatized, people who have ADHD, go through childhood trauma, don't develop PTSD that badly than other people. Because the memory just doesn't stay. It maybe stays somewhere in the deep inside, but not in the RAM memory, I call it. The ADHD memory is the RAM memory, whereas this is the deep hard drive memory. But when you treat it, it comes back. So quite often people with ADHD describe, well, my flashbacks are coming back, or I've never had flashbacks, and then I'm now getting them. It's not a side effect of medication. It's just the memory stores being opened up. Again, with borderline, and I'll show you one, I keep saying last slide, but this is the mood swing pattern. Sorry. Please, yeah, that's my card to them. If you think of borderline personality disorder, and again, people who know with the psychology, I'm sure most of you read basic psychology. When we say personality, so personality disorder would have a personality. We can't call anybody's personality till they're 17 or 18, because all of us are developing, aren't they? There's a dynamic change going on till we are 17, 18. And after that, our personality kind of crystallizes. We remain who we are, roughly. So calling anybody personality disorder before the age of 18 is actually not right. I mean, scientific literature definitely. So if that illness started at 18, or you can't diagnose it till 18, but something very similar to it is there from childhood, why not think of that instead of the BPD? So my take-home message is, well, amongst other things, if you see a diagnosis of BPD, please check again for ADHD. If you see a diagnosis of bipolar, please review it, please review. And keep an open mind. It can happen along with things, but it can happen in addition. I think I'll let everybody go unless there are questions. I've got lots of slides if people want to. I can talk till you guys get bored. History of ADHD?
No, you're done.
I'm done? Oh, okay. Questions? Anyway, thank you. Okay, thanks for coming.